Hi, Dr. Ivanina. How are you?
Siobhan, it's so good. It's so good to see you.
It's
I was
good
for
to
a
see
second,
you
I was
too.
like, wait, is this good? Are you
You're
like talking?
good. You're good. We love having you here. Thank
Thank
you
you
so
so much
much
for
for
having
joining.
me.
Happy SIBO Awareness Day, my friend.
Indeed. Changing lives, right?
That's
That
right.
thing. My goodness.
That's right. So, Dr. Ivanina, be sure
Yes.
to find her on social media. You have a really strong Instagram presence. So I love that. Thank you so much for all of that. And just speaking of social, someone's asking about what's the name of my Facebook group. It's SIBO SOS. I think it's like virtual summit or communities. Look for the SIBO SOS. And SOS has come to mean save ourselves in conjunction with working with highly skilled professionals. So it's great to have you. I know Dr. Rezaie is going to be joining as well, and we are going to get going with your segment. Very, very
Terrific.
glad to have you here. All right. Can I just pop a couple questions your way as we get ready for your official segment with Dr. Ali Rezaie?
Let's do it.
Okay. Well, first of all, let me give you the proper intro there. And that you are the GI and founder of the Center of Integrative Gut Health. You are quadruple board certified integrative gastroenterologist specializing in root cause diagnostics. That is amazing. Thank you for your commitment to education and helping so many people. That's fantastic. That was very
Thanks,
cool.
Siobhan.
Yeah.
It's triple boarded just to
Okay.
little
Somebody said quadruple. We'll take it. Oh, just triple. Just triple. That's amazing. Well, congratulations on that. And thank you for all of your help.
Thank you.
Do you see people who have been on metformin being impacted with SIBO disproportionately?
People who are on metformin.
Yeah.
I don't think so. I honestly have not seen a lot of people on metformin anymore since the rise of GLP-1s. I'll have
Yep.
to say, metformin, of course, has been on the market for a long time, and people use it for insulin resistance from PCOS to, of course, diabetes, types 1s and 2s. And I think it's an interesting connection to make because I think you wonder if it's due to the actual medicine versus the condition that the patient
Right.
has, right, Siobhan? So I think
Yeah.
like we understand that people, if they're taking it for PCOS has been linked to dysbiosis. And so the question is that a dysbiosis, that could be SIBO? And the same thing with, we certainly know type 1 diabetes for sure as an autoimmune disease. And especially since it's connected with exocrine pancreatic insufficiency, we know that that's associated with SIBO. So I think, I don't think I've seen any evidence that the compound itself causes SIBO. I
Okay.
think there's a question about the condition it's treating. And also, we do know decreases B12. And then a lot of people wonder, okay, is the B12 from metformin or SIBO or what? Yeah.
Exactly, which came first. Now, someone is saying that they heard their doctor saying that SIBO has exploded after COVID. Do you see that in your practice?
Absolutely. Absolutely. I think that there are studies published from China after first wave COVID that showed, again, like really early on, we knew there was dysbiosis. We knew that there are receptors for COVID in the gut. We knew that the gut was playing a huge role. A lot of people have gut symptoms. Now, of course, not every type of COVID has had the same impact. As we go through different strains, I think it's been variable, but
Yeah.
there's no question, I think, that the dysmotility that happens post-COVID, we know that there's been an uptick in gastroparesis, in POTS, in MCAS, and SIBO is something that, of course, is so common with all of these conditions. So yes, I definitely agree, Siobhan.
Okay, and what about if someone is underweight? Can they do the elemental diet?
That's a good question. So I think that the great thing about Embiota and the research around,
Yes. Hey, representing. Yeah.
the research around it is that it's complete nutrition. And I think that in certain situations where patients are perhaps malnutritioned, they're malabsorbing from their SIBO, from their Crohn's, from all the different primary etiologies that can cause so much malnutrition. Again, with the right team on board with the right nutritionists and practitioners on board, Siobhan, I think that, yeah, absolutely, it can be done. You just have to be really careful, right? You have to understand antibiotic, each packet's 300 calories. You have to
Right.
understand how many calories a patient is going to require. So I find a lot of patients, I actually use Embiote even as a supplement for gaining weight.
Yeah, I've seen that a lot too. Hi, Dr. Rezaie.
Hi.
It's so great to have you here. And I know you're coming in directly from Cedars-Sinai in Los Angeles. So thank you very, very much for taking the time out of your day too. And Dr. Ali Rezaie, gastroenterologist and medical director of GI Motility. He is a leading voice in GI motility research with over, count it, 300 publications. His work has transformed how we diagnose and manage SIBO. It's good to see you.
Great to see you guys.
Good to
See
see
you,
you.
Elena. It's been a while.
Yeah.
What a-
Not a while, actually. We just had
We
the
talk a lot.
podcast like 3 weeks
Did
ago.
we just do
but
that?
Anyway,
Well, that is a dream team right there. And I know you're going to be talking about the long-term treatments and maintenance, I should say, for SIBO and IBS. I'm going to hide myself while you two geniuses download for us, and then I will see you on the other side of your presentation. Thank you so much.
You're so kind. Well, thank you again so much for having us. I am so excited to be part of this event and raising awareness about SIBO, as I have seen how the diagnosis and treatment changes so many lives. And so together today with Dr. Rezaie, we're going to be discussing treatment. So just to kind of outline next steps, I'm going to talk about the approach, evaluating root cause, and then the importance of a 3-phase approach. Then Dr. Rezaie will discuss the best studied treatments, antibiotics, and elemental diet. And then finally, I'll discuss the less studied treatment options, natural treatments, herbal antimicrobials, microbiome manipulation, and how to safely approach them. So many people out there are struggling with a SIBO diagnosis, I think, because they just don't have the right testing or guidance and support to get them through the treatment correctly. And so to set yourself up for success treating SIBO, I really think it's key to identify and address your root cause and then approach treating SIBO with a multi-phase protocol that focuses on eradication, maintenance of motility, and then really repopulation and focusing on preventing recurrence. Not going to go too much into the different root causes, but wanted to just mention a couple things. First and foremost, you need to understand why you got SIBO. As I think many have probably heard, SIBO is due to something, and you really want to find and address your something if you want to ensure that your treatment is going to be successful and your overgrowth does not come back. So I've seen so many times patients who have treated SIBO successfully, they feel so great, but it's temporary and it recurs from days to months later. And so I really like to think about the root causes, thinking about different categories: structural, like adhesions; motility, post-infection with antivinculin issues and MMC issues; sometimes things like SIPO, chronic intestinal pseudoobstruction. Like to think about stomach acid. Does H. pylori or PPIs play a role? Like to think about medications, antibiotics and opiates; immunodeficiency, like IgA deficiency; organ-specific diseases, like we were just talking about before, type 1 diabetes, and how, of course, that affects the pancreas and exocrine pancreatic insufficiency; hypothyroid, also recently published on, and its connection with SIBO; autoimmune diseases, IBD, especially Crohn's; inflammatory bowel disease, so Crohn's, celiac, scleroderma. And then there's a bucket of other, and one of those is something like EDS. And I wanted to just talk about a couple points within the root causes. One of them is really Crohn's disease. Studies have shown that there are increased rates of SIBO in IBD patients, and especially more frequent in patients with Crohn's. I can't tell you how many patients with recurrent SIBO I have rescoped because perhaps the terminal ileum, the end of the small intestine, was not intubated on prior colonoscopy. And so when I rescope them, we find Crohn's disease. Literally, this happened yesterday. And so again, you need to understand that there's Crohn's. Why do they keep relapsing? You have to treat the Crohn's. I also want to emphasize EDS and the triad: EDS, MCAS, and POTS. We talked about this a little just as the intro, talking about post-COVID. I see so much SIBO with this triad. I feel like it should be renamed tetrad with SIBO. Because you see a lot of visceroptosis and EDS. Also with MCAS, there's altered motility from the mast cell mediators that can affect MMC. And so again, like these are conditions that are all so important to talk about, to look into, because they can really change the trajectory of someone's healing protocol. And then the final important tidbit is don't forget to look for conditions that happen at the same time as SIBO, like SIBO, small intestinal fungal overgrowth. And so there have been studies by gastroenterologists like Satish Rao that showed there have been patients where SIFO is present in about 25, 26% of people with unexplained GI symptoms, especially also prevalent in EDS. He did a study and it showed that actually 25% of the subjects with EDS Dr. Rao looked at had both SIBO and SIFO. Okay, so now that we've got that first section of root cause down, someone's gotten tested, they found out they have SIBO and which of the 3 types of SIBO. They've identified their root cause and talked about, could there be something else going on as well? Now you move into the multi-phase protocol. And so again, first phase, eradication. It's about choosing the correct treatment for the specific type of overgrowth that you have. And Dr. Rezaie will speak about the best studied eradication methods, and I'll speak about the natural ones. But then phase 2 is maintenance and motility. That's about optimizing motility with prokinetics, assisting your migrating motor complex with things like meal spacing, making dietary changes such as low fermentation diet. And during that phase, many will also test for eradication to see the results of how phase 1 worked. And then finally, repopulation and relapse prevention. So with guidance, after you've tested and you've cured SIBO, you want to work to improve your gut health. So food, supplementation to strengthen your gut microbiome abundance, diversity, and of course, specific things to prevent relapse. Like if you're traveling to Mexico, you want to consider taking prophylaxis. If you have a history of post-infectious IBS with elevated antivinculin levels, you want to consider taking prucalopride long-term. So again, this approach is often missed for a lot of people. And I think if you keep it in mind, will really be an important part of healing your SIBO. So, okay, Dr. Rezaie, take it away.
Yeah, that's fantastic. Thanks for that overview. And that's actually one of the main points. Yeah, I can talk about eradication all day, but that finding of the root cause still should be top of our minds as we do the eradication or maintenance of remission therapy. Because at the end of the day, if you can find a root cause that can be addressed, then you can potentially cure the disease. And that's very clear. Example that Dr. Ivanina said is that we do see it as well. Somebody with Crohn's disease. Well, no matter how many times you treat it, then the disease will come back.
Yeah.
So you just need to get rid of that inflammation in the small bowel that has led to this motility, that has led to dysbiosis, that is causing all these troubles. And now, why Crohn's disease can cause a SIBO, and there is no shortage of studies showing that there is a big overlap between Crohn's disease and SIBO. That can be because of the small bowel not moving. Because think about it, the small bowel is inflamed, it's not moving. And also, very commonly, Crohn's disease affects the terminal ileum, which is the last part of the small bowel where the small bowel connects to the colon, and the ileocecal valve is there. Obviously, it affects the function of that valve. So all those points together leads to a higher rate of SIBO. And when you get rid of the inflammation, granted that there is no stricturing, there's no fibrosis yet, then the patient responds really well to treatment of SIBO. And sometimes just an induction of remission is enough. Then the patient does well as far as the inflammation in the small bowel is under control. So the point I'm making is that finding the underlying cause is very important in terms of management and also in terms of reassurance, because a lot of patients want to know, like, why do I have this to begin with, right? And that is very key in management of patients and for them knowing why this whole thing happened. So in terms of induction of remission, as Dr. Ivanina was saying, the grandfather of things is using antibiotics, right? Because remember, SIBO has been defined for many, many years. Originally, it was defined in patients with Billroth 2. Billroth 2 was a surgery that we used to do prior to antacids that would essentially juggle the bowel. Essentially, we have two lumens of the bowel. We would take somebody with gastric ulcer, take that ulcer apart, attach the remaining healthy stomach to the rest of the small bowel, and the other part was just having a blind loop and things would go through. People forget that what a miracle antacids were. We were doing Billroth 2, like so many of them, in 50s and 60s and 70s, and everybody thought it's all stress and smoking and all that. And then obviously two big things happened. Number one, H. pylori was discovered as the cause of gastric ulcer, which again is microbiome related, something that was sort of denied and frowned upon, that a bacteria can cause ulceration. And that led to a significant drop in the number of symptomatic gastric ulcers that we have. And secondly, the antacids, first H2 blockers, such as Pepcid, as you know, and then PPIs. And now we have even stronger medications like vonoprazan that are out there. That decreased the amount of gastric ulcers and subsequently the surgeries that we're having for them. But while we were doing those surgeries, the blind loop of the bowel was found to be full of bacteria. Why? Again, as Dr. Ivanina said, so there's the movement if it gets affected. Now you have surgery, obviously now bacteria overgrows. So the treatment in that setting that was started, and this goes back more than half a century back, was antibiotics. And in that setting, usually you have to use systemic antibiotics, and that's actually a good parallel there. People with Roux-en-Y surgery and bypass surgeries, even for obesity, if they have SIBO, it's preferable to treat them with systemic antibiotics rather than non-absorbable antibiotics such as rifaximin, because rifaximin goes through the lumen but does not go through the blind loop. The same goes actually for treatment of SIBO, as Dr. Ivanina was saying. In that setting, I use systemic antifungals because if I give nystatin, for example, this goes through, well, doesn't go through the 70 centimeter, which is about 2 feet of blind loop. So antibiotics, which ones do we use usually in the setting of SIBO? There are multiple studies going back to 80s that people tried to see what is the most effective antibiotic. People have tried metronidazole. Flagyl is the brand name that we commonly use. People have tried amoxicillin. People have tried neomycin. People have tried ciprofloxacin. One point about ciprofloxacin is that we don't use it first line anymore, and that's because of the black box that we have with fluoroquinolones, which is the umbrella term for medications such as ciprofloxacin or levofloxacin that can affect the joints. So because of that, we avoid that. Having said that, there's still a very commonly used antibiotics, but again, in the setting of SIBO that we know, they may need multiple rounds of antibiotics. That's not what we reach for on first hand. Another antibiotic that I use is doxycycline, good old doxycycline, although there aren't many studies on it. It's well tolerated and it's generic that we use. The issue is that some people get pill esophagitis with it, meaning that they get inflammation of the esophagus, especially when the capsule is not passing through. So make sure that if you take doxycycline, you drink good amount of water after it. Don't lay down for a good half an hour after taking a doxycycline. And the poster child of the antibiotics used in the setting of induction of remission to treat SIBO is rifaximin. The rifaximin is a poorly absorbable antibiotic. So what do I mean by poorly absorbable? 99.6% of rifaximin doesn't get absorbed. It just goes through your gut and we just literally poop it out. And because of that, it has very minimal systemic side effects or systemic effects as well, as opposed to other antibiotics. And that's why we like rifaximin in that setting. Obviously, one issue with rifaximin, at least in North America, is the cost. And that's because it's still on a patent. And that's something that will hopefully resolve in a couple of years when it goes off patent and rifaximin will become generic. So I guess that's pretty good news for a lot of us patients and providers because it's rather expensive to get it in the US. So the dose that we usually use is 550 milligram 3 times daily for 10 to 14 days. 14 days is more common because that's the dose that is also approved for IBS diarrhea in the US. But studies done within 10 days have been successfully eradicated. And in fact, the original dosing for IBS diarrhea came from the Stefano study in Italy that they tried 400, 800, 1200, 1600, and 2000 milligram of rifaximin per day. And they saw that 1600 and above is effective. And actually, that's where 550 milligram 3 times daily dosing of rifaximin comes from. That study with the Stefano that showed 1600 milligram per day is effective for eradication of SIBO. So that's a kind of like overview of the antibiotics that we use in the setting of small intestinal bacterial overgrowth. Now, if you want to talk about SIBO, so that's also we use nystatin. The protocol that we use, I follow what Dr. Satish Rao recommended in this setting, that I tried 21 days of treatment. Now, that can be systemic antifungals such as fluconazole, or it can be nystatin, which is poorly absorbable, almost unabsorbable antifungal. It's the same compound that we use for thrush in infants. So it's a safe medication. It comes in liquid form and also tablet form. Just remember the liquid form has saccharin in it. That's why it feels very sweet. But interesting enough, if you go back, saccharin actually has a little bit of an antifungal effects to begin with. So that's why I think this compound start like going back to 70s had saccharin in it. So that's kind of the main induction of remissions modality that we use. Now, some people can't take antibiotics. Some people have had allergies to it. Some people are intolerant to them. And some people prefer something that does not involve antibiotics, considering whatever reason behind it, whether intolerance, allergies, a drug interaction. And that's where we use elemental diet in that setting. So elemental diet, obviously, we can go very in depth about the clinical trials that have been done, but that's one modality that we can use. I kind of talked way too much, like back to back, but I just wanted to see what Dr. Ivanina has to add before I go into the elemental diet part.
I always learn something from you every time we speak. And so really fascinating to hear about the history and evolution of SIBO. And, that other antibiotics are also used, but of course have potential side effects. And just curious, just again, like breaking it down into hydrogen, H2S, and methane, right? As far as antibiotics go, you know, you can just talk, if you don't mind, about each category. And then like something like doxy, like where would you place that as far as like the 3 different categories?
Yes. So when we do the breath testing, it can come back as hydrogen, hydrosulfide, or methane. In the setting of hydrogen, the antibiotics that I use, I reach for rifaximin first. And if that is something for whatever reason, whether it caused issues or patient has had bad reaction to it or no response to it, then I reach for other antibiotic. And so very rapidly, doxycycline, and I have to admit, that's anecdotal for me, has become like the second line for me that I use because it's twice daily, 10 days, and patient tolerate is generic. And as long as they drink water, that helps them. Other options, amoxicillin, but the problem is the amoxicillin patients get diarrhea. They don't like it. It gives you cramps. Having said that, again, that's another accessible antibiotic that you use. When there is methane, obviously now the issue becomes that methane producing microbes are archaea. And Archaea versus bacteria, these are completely different living organisms. In fact, actually, the domains of life, I don't know how much you remember, guys. So it's life, and then there are three domains of life. One is archaea, which were the first guys showed up on our planet, and they produce methane, some of them. And the only source of methane pretty much on our planet outside of like volcanoes and chemical reactions are these guys. And funny enough, this methane production kind of were forgotten in the neck and the rest of the domains that showed up later on, which are bacteria and then eukarya. And eukarya is huge. Now that includes fungi, that includes animals, insects, us, everything, right? And remember, we are all three. So essentially, we're eukarya as a self. And then inside our body are the bacteria and archaea inside of us. So fungi and everything. So we're a combination of all that are just hanging out there. So the cell wall of archaea are different from the cell wall of bacteria. And throughout history, bacteria have been the bad guys in terms of killing us and being able to affect us dramatically. So that's why the majority of the antibiotics that have been developed in modern history affect the cell wall of the bacteria. But the problem now is that archaea have a different cell wall, and these antibiotics that work on the bacteria can affect these guys, right? Except for a few antibiotics such as metronidazole or neomycin that are effective against archaea. And that's actually very key when we want to suppress the amount of methane production. So you have to use a specific antibiotics to suppress methane productions in those guys and also suppress their growth. Now, on top of it, methanogens, i.e. methane-producing microbes, they need hydrogen to produce methane. By the way, that's not something that only happens in our body. It happens anywhere. When you go to a quagmire, when you go to whatever mine, that methane that has been produced by a archaea has been using hydrogen produced by a bacteria close by. And these are called centrals. They just live together. They just hang out, right? So if you suppress hydrogen production by the regular hydrogen-related antibiotics, so obviously you decrease methane production too. So that's why we use combination therapy in these patients. For example, the classic one is rifaximin neomycin that we use. Neomycin is poorly absorbable. So that's why we like it. Having said that, there are case reports of it affecting hearing. I personally, over the last 12 years that have been prescribing it, haven't seen that. And also in the prospective trials, that people haven't seen that. But again, that's a possibility. The other option is rifaximin plus metronidazole. Now, if rifaximin is not available, options that I've used is ciprofloxacin plus metronidazole. Again, I'm not in love with the ciprofloxacin, so I try to avoid it. And also I have tried augmentin too, that has worked relatively well in patients. But also remember, if you're out of options for hitting archaea, you can use neomycin. Patient has a reaction to it. Metronidazole, sometimes some people get really bad nausea with it. They don't like it. So in that scenario, you can use rifaximin alone, even though it is not as effective. But that is something that has been shown up to 43% of the times it can suppress and improve things. So that's one thing to remember, that you're not out of luck in that scenario. And the last part in the setting of the sulfite producing bacteria, obviously we're learning more and more about these. They're a giant group of bacteria. So it's not that every single one of them is a bad guy. But traditionally, one thing that we know that can suppress sulfur production is bismuth. Bismuth is actually an element, but actually behaves as an antibacterial as well. And that's why, for example, we use it in treatment of even H. pylori, that we use it in that scenario as well. And that's why, for example, Pepto-Bismol is a very effective treatment for traveler's diarrhea and even prevention of traveler's diarrhea because it has an antibacterial. In fact, actually, there was a large prospective trial that showed, yes, it decreases traveler's diarrhea if you try the good old Pepto-Bismol. But, the active ingredient of Pepto-Bismol is the bismuth.
Mhm.
By the way, when you take bismuth, a lot of patients send a message with panic. You can get a very black discoloration on your tongue, and people are like, "Oh my God, what happened? Is that like mold? What is that?" That's just bismuth. Don't freak out. And also, it changes the color of the stool. It gives you a very super dark kind of color, but it
Mhm.
doesn't become tarry. It's just super dark. So it's not blood, it's just the bismuth. So don't freak out when you take bismuth. So what I was saying is that if somebody has excessive amount of hydrogen sulfide and has diarrhea, I commonly use bismuth as an adjunct therapy as well. But I use rifaximin in that setting as well. That helps the patient. Anything else I should cover?
No, I had one kind of question before you move on to elemental, which I feel holds up a lot of people's decision to take antibiotics for their
Mhm.
SIBO, which is they've taken antibiotics before, they've caused gut issues, right? And some of them actually were fine before they maybe took a couple courses of antibiotics for UTI, sinusitis, right? You name it. I was wondering if you can talk about rifaximin specifically, just because it is such a backbone of SIBO treatment for all
Mhm.
three types. Does it affect the good bacteria in your gut?
Well, I mean, first of all, microbiome field is dynamic as it's improving. And like now we have new techniques and everything. So what I'm going to say is based on what we know now. Now, what happens in the future, I don't know. So bottom line, what's interesting about rifaximin is that it's quite effective in the small bowel, but then it crystallizes in the colon and it doesn't affect the colon as much. That's
Mhm.
actually interesting. Let's segue here because rifaximin has also been used in the setting of diverticulitis, which is a colonic disease, right? Think about it. But that again shows you that modulation of small bowel microbiome can treat disorders of the colon related to microbiome. And the classic example of that, trying oral fecal transplantation in patients with C. diff. So it's kind of naive to think that kind of like pupil, as we call it, would get all the way to the end of the colon. It's not. It's essentially
Right.
modifying the small bowel microbiome, and that actually
Mhm.
leads to eradication of C. diff. So it's kind of like interesting concept. So because of that, the effect on the gut microbiome in the colon, which is the big bulk of our microbiome, has been minimal. And it has no antifungal effect, and it has no antiviral effect, no antibacteriophage effect, and all that. So it doesn't affect that. So Mark did a study that they looked at the stool before and after rifaximin, and this was part of Target 3 trial, which was the FDA-approved clinical trial to assess rifaximin in the setting of IBS diarrhea. But some of them underwent the breath testing, and it turned out two-thirds of IBS diarrhea patients have SIBO, not surprisingly. But they also underwent stool testing before and after rifaximin, and they saw very minimal change in the amount of gut microbiome. Also, we need to look at other disorders that we use rifaximin in, right? So rifaximin is also approved for hepatic encephalopathy. Just to explain what hepatic encephalopathy is, so when we have a very sick liver, liver, one of its job is to get rid of toxins, right? We call it the first pass. So whatever you digest and bacteria produces and all that, it goes through the bloodstream, goes through the liver, and liver filters that and takes the bad guy out, detoxifies it, and sends the blood into the systemic blood flow. Now, in people with cirrhosis, when liver is not functioning, so that first facet's gone, some bacteria in the gut can grow and produce compounds that lead to encephalopathy, which starts with the sleep cycle abnormalities all the way to tremors, and also the end stage can be even like coma. Now, when you give these people antibiotics, they get better dramatically. And that's actually one of the best examples of brain gut axis, if you think about it. That's essentially gut is producing things that completely affects the cognition.
Yeah.
So that medication has been approved by FDA since 2015, if I'm not mistaken, for hepatic encephalopathy. And we have patients that go on this medication twice daily for more than a decade that we have these patients. And in fact, I think it was 2012. So more than 10 years they have been on it and they're doing fine, right?
Yeah.
And I don't
Yeah.
think we have any more long-term data on any other antibiotic that tells you that, okay, these guys are doing fine. And in fact, data points towards the fact that people on long-term rifaximin with hepatic encephalopathy have less hospitalization, have less sort of worsening of their symptoms, and they're doing better. So again, doesn't guarantee that it's perfectly preserving our gut microbiome, but that's that's as good as it gets kind of data. Now, there was a couple of basic science paper recently came out, one of them in Nature that came out, that suggests that long-term use can potentially affect some of the resistant bacteria in the colon, which that data is out there. And now there's a study actually ongoing in Taiwan. Maybe it's published already, but just reviewing it. And that kind of like confirms it. That it was like, okay, we don't see any clinical endpoints that are worsening with this, but hey, they're popping up. And
Yeah.
that's something that's it's on people's radar. And obviously, as our techniques to assess gut microbiome is advancing, and also these days we don't go and grow the bacteria and see if they're resistant to bacteria by putting pellets on it right now, right? We don't do that anymore. What we do is that we get those bacteria and we look for the resistant genes inside of them, right?
Yeah.
So that has revolutionized things. So now instead of me going and growing things and say that, okay, does it work, does it not work, and all that, that has advanced that field dramatically. And we will hear about that more and more. And I wouldn't be surprised that there is no signal there. There should be something, but how much that affects us clinically, we don't know. Having said that, using it intermittently, we have done that for many, many, many years, and I haven't had issues with it. In fact,
Yeah.
remember, one of the off-label uses of rifaximin, in fact, were commonly used in Europe, is for in the setting of C. diff, that we use the rifaximin to treat C. diff, which we know is a disease that comes most of the times because of somebody taking antibiotics. So we treat it with rifaximin. So again, small microbiome modulation leads to improvement of some colonic microbiome disease, which is a fascinating concept there. Yeah.
So much information. I love it. I love it. Do you want to jump in to
Elemental diet, right? Let's do it.
elemental? Yeah.
Yes, so that's a big topic, and I think it's getting hotter and hotter. And I'm happy that it's getting hotter because obviously, if we can treat things through diet, that's a very clean way of doing things. So, just to step back, elemental diet, everything that we eat, it has protein, carbohydrate, or fat. And also, on top of it, we need the elements and also vitamins to survive. That's pretty much all we need. Roughly 70 ingredients. And with that, we can survive. So all of these need to go to your gut and get digested. Carbohydrates, very complex. They need to get digested and we absorb it. And the final products usually monosaccharides like glucose and fructose, and they get absorbed. Lipids need to be broken down to fatty acids, and also proteins need to be broken down to amino acids, right? So this process actually it's very costly. And one of the reasons that the humans evolved to go all corners of the world is that we figured out how to do it as opposed to a lot of other animals and living organisms, because we can survive on different sources of food. Having said that, it costs us. It's about 20% of our daily calorie expenditure is used to break these food down. So it's a lot of like energy. Also, it's like there are hundreds of steps for these foods to be broken down to those pieces. And, those steps can go wrong. There's a lot of enzymes that are involved, genetic mutations, or any disorders that can affect these enzymes that we can't absorb it. So elemental diets were evolved, and going back to even 70s at that point, to have all these food as pre-digested, all those elements, so we can take it. Some trivia over there is that one of the first reasons that this was developed was that one of the biggest problems you probably heard on the Artemis recently, pooping in space is not fun. So the bathrooms and space stations are a little bit nasty, and also they're just vacuum. They just put it in and they just suck everything out. So considering all those challenges that in 60s and 70s astronauts had, they were like, okay, can you give us some sort of food that has no residue? So essentially, I don't poop, I just absorb everything. So they tried this at the beginning there. But the problem is that even when we don't eat, there is constant flow of food through our gut by sloughing our gut. Remember, our gut sort of renews every 5 days.
Yeah.
And cells just fall in, and there's bowel secretions and all that. So even if you are not eating anything, you will continue to poop a little bit. So that problem can't be fully solved in space. So you have to sit on those vacuum toilets, which, as you heard, broke down for the first few days in Artemis. I don't know what they did, but anyhow, I don't want to know. At the same time, they figured out, wow, they have multiple health benefits. And now these health benefits are for multiple sort of reasons. Number one is that they have amino acids instead of proteins. Remember, allergens are proteins or peptides. If you have amino acids, they can't be allergens, right? So our body doesn't react to it. So by definition, they're allergen free. Obviously, they give us a little bit of a reset and rest in the setting of our eosinophils and mast cells in terms of exposure to food allergens. So that's number one. Number two is that they are very low fat. So that's why chronic pancreatitis patients that are very sensitive in digestion of fat are helped. They get absorbed at the beginning of the small bowel, and the rest of the gut doesn't see food, similar to a pseudo fasting state, meaning that you're eating, but the rest of the gut is not seeing food. So you get some of the benefits of fasting, intermittent fasting with elemental diet. And they're anti-inflammatory, and also they don't have food additives, right? So there is no questions. All the sweeteners, food colorings, microplastics, and all that, they're harming us. But the thing is that we can't avoid them. They're everywhere, right?
Yeah.
So they don't do that. So obviously, they don't exist in the elemental diet. So you're not exposed to it while you're taking it. And many other reasons. Modulation of microbiome is being one of the main ones. So it turned out that they're effective in Crohn's disease, not surprisingly, eosinophilic esophagitis, not surprisingly, eosinophilic gastrointestinal disorders, and short bowel syndrome, chronic pancreatitis, and also SIBO and EMO. The original study was a retrospective study, which was done with the old school Vivonex Plus, which is made by Nestle. But the issue with that is that they taste foul. The amino acids actually, they're very sulfury. It's almost like a rotten egg when you have it. And I've tried it. So that was a positive trial. But the thing is that many people can't do it. Up to half of my patients after the first sip, I was like, okay, man, forget it. I'm out.
Yeah, terrible.
But now with the advancement of flavor masking and food engineering, now, for example, Embiota has figured out how you mix all these together and in what way and in what concentration that makes it palatable. And that's when we did the clinical trial a couple of years ago, where we gave it to 30 subjects and participants with EMO and SIBO. And for 1 week, they were just at the baseline. 2 weeks, we gave them exclusive elemental diet. They were allowed to have as much water as they want. They could have black coffee. And also they were allowed to take as much elemental diet as they want. And then 2 weeks of follow-up, they reintroduced regular diet. The key was that 100% of these patients were able to tolerate the diet, which was a big advancement as opposed to roughly 60% of other clinical trials because it was palatable. So that's one big advancement and showing that palatability increases tolerance. And also we saw that 73% of the patients at the breath test normalized, and also 83% of the patients had symptomatic control.
Mhm.
One interesting thing is, and that's the difference with elemental diet and antibiotics. What we saw with the breath testing is that when we do breath testing, we see a rise in like hydrogen in the SIBO that goes up before 90 minutes. But in normal subjects, the rise happens after 90 minutes, which is the normal colonic fermentation. When you use antibiotics, you even lose, especially systemic antibiotics, you lose the colonic peak as well because you just decrease the amount of bacterial load even in the colon. But with the elemental diet, you don't see that. Actually,
Hmm.
this early rise kind of shifts all the way to the colon. So you switch an abnormal small intestinal fermentation pattern with a
Mhm.
normal colonic fermentation pattern, which is very key in the setting of elemental diet. So that's one thing that we saw, and it was very impressive. But for the methane, it just kind of like suppressed it. And we kind of proved that with using the PCR of the Methanobrevibacter smithii, which is the most accurate way of seeing how much Methanobrevibacter smithii, which is the methane producing guy in the colon. And we showed that. Also, reassuringly, we saw that the core microbiome, which is the fungal component of
Mhm.
the colon, was not affected. This is Saccharomyces cerevisiae. You probably have seen some of the probiotics of that. And
Mhm.
also, Candida actually dropped by twofold. Because one of the worry that we have with antibiotics is fungal bloom. Because, in real life, fungi and bacteria are constantly fighting. Now, you give antibiotics, well, fungi is like, thanks, you killed my competitor. Now I'm just shooting up. I'm blooming, right? But with the elemental diet, the mechanism of action is different. And now you have the normal flora starting to grow back. And now that starts to keep the bad bacteria away, also keeps the fungi in check too. So it doesn't allow them to go nuts. So that's one interesting thing that we saw. And also we saw sort of other benefits as well. So that was a very sort of a positive point. Did I mess up
Dr.
timing?
Rezaie,
I
no, you're
see
fine. You're fine.
Siobhan.
I have a question. Wasn't there like 100% remission? Like, isn't there 100% statistic floating around?
Yeah,
The high.
so the
Could you
for
just
the
repeat that
SIBO
for me? Because
patients,
that's my
so
favorite
yeah,
part.
so there were like different subgroups of patients.
Yeah.
Patients with SIBO alone, people with no methane, only hydrogen, their actually eradication rate was 100%. But obviously, this is limited
Amazing.
number. So
He doesn't want
obviously,
to
if you do
overpromise
it on
everybody. He doesn't
1,000
want to
patients, it's not going to
overpromise.
be 100%.
Yes, I understand.
Yeah.
We
Yeah.
understand.
So yes, correct.
But I just like, for those of you who think that like there's no hope, right? That you've tried everything, that it's no one ever cures it. Because we come to these SIBO awareness days and different events and masterclasses, and we're just talking to people who are still suffering with it. So it can be in many, many cases eradicated. And then you do your prokinetic to help, with long-term
Yeah.
relapse prevention, et cetera. Did you, either one of you wanted to touch on anything else before we got to a massive amount of Q&A?
Oh gosh.
Oh my God. No, I think Dr. Ivanina wanted to talk about the other options that we have available.
Yes, the herbals and et cetera.
Yeah,
Yes.
Sure, I can breeze through. There's very little data. There's very little science behind it, like there is behind, right, the history of SIBO and the history of elemental diet, right, which, like you said, has been around, for some time. And I did that taste test, and I forget if it was DDW or ACG. Oh my gosh, that Vivinex was so bad. But yeah, I wanted to talk about the lesser known, lesser studied way to approach eradication and really how to do it safely, because I see so many patients that will come to me who have been on some of these supplement protocols for months, and they've been malabsorbing and they've been losing weight. And it can be done, in a way where I think patients can really struggle, or I think that with the right practitioner, it can be done in a way that is actually very safe and can be very helpful. And so I have a lot of patients come in and ask about these like natural approaches, which I think can be a possibility for some patients. And I think that the key is you have a specialist on board, make sure, the specialist can have access to testing, right? Of course, we need to have normal liver function. We know that herbal combinations can be hepatotoxic. So before you embark on these protocols. You want to ensure good liver function. You might want to recheck it while you're on it, depending on what issues arise. And of course, also then when to quit and move on to another approach, because it's also not for everybody. And I just wanted to talk about, there are really two papers, and that's really it, that have looked at herbs in SIBO. One is the famous one I'm sure everyone here has heard of, about the equivalence of rifaximin to herbs and treating a SIBO. And the other one is actually the oral botanical supplement with, and also looking how to treat SIBO and facial redness, interestingly. And that one looks at biocidin. So the first one is the one from Hopkins, looking at candibactin ARBR. They also looked at dysbiocidin FC-cytal. It's about 100 patients. And interestingly, actually, when you were talking about just before the dosing of antibiotics, right, they interestingly dosed their antibiotic arm at 1,200 milligrams daily. So again, not really the dose that we use typically right now, right? 550 TID 3 times a day. So interestingly, they had their two arms. They had rifaximin 1,200 daily, and then they had herbal therapy for 4 weeks, right? So again, candibactin ARBR. AR is mostly things like oregano oil, thyme oil, sage leaf, and then BR is mostly berberine and also other things like Oregon grape and coptis. And then the spy side, again, another mix: wormwood dill, FC-cytal, thyme, olive leaf, tarragon horsetail, and some other things. And so out of these patients, again, not a lot of patients in the end, it was 37 who received herbal therapy. 46% had a negative follow-up breath test compared to 34% of rifaximin users. Not statistically significant, p-value was 0.24. But, I think that there was, again, a signal that it could be used. It can help some people, and it was found to be safe. There's actually only one case. The only side effect reported was one case of diarrhea in the herbal therapy arm. And so again, I think that you look at these studies and you can work with the practitioner to have an approach that is safe. Obviously, again, seeing that there is at least some kind of study done, especially to look at the safety and the duration and the dosing. I like personally the candibactin protocol because of the berberine. There's actually a DDW abstract looking also, I think it was a non-inferior study to rifaximin, and it was just the initial interim analysis that they looked at. Also, again, like showing that berberine can actually be a terrific microbiome modulator, both to decrease overgrowth and actually also to increase some of the beneficial microbes. The other study, just quickly, was another small study again. It was 19 out of 33 adults that were screened, found to have SIBO. They were given 10 weeks of a biocidin liquid and GI detox. So the biocidin, actually kind of similar ingredients, right? You've got the oregano oil. They also have things like black walnut, tea tree oil. And the GI detox, interestingly, is what we refer to as a binder. So it's got these clays, activated charcoal, also something we use. I'll also suggest with bismuth as, sometimes helpful when you're traveling. So together, if participants were found to be non-responsive after the 10 weeks, then they would add even one more supplement, which is called Oliverex. That one is mostly olive leaf. There's some other uva ursi, milk thistle. Again, a lot of different herbs together. And what they found in the end was that this was actually a pretty decent approach for hydrogen and hydrogen sulfide dominant SIBO. So with hydrogen, 42% eradication, negative breath test, and hydrogen sulfide, actually 66%. One person dropped out, I think, because of headaches. And again, not for emo. They didn't have a lot of emo participants. And so there's not a lot of good emo data. But again, for hydrogen sulfide, not bad. And then I also did want to really touch upon microbiome manipulation, right? So there's this idea of the crowding out method, prebiotics, probiotics, and then of course, microbiome manipulation like fecal transplant. So very few studies looking at Saccharomyces boulardii. But again, like Dr. Rezaie said, in patients who usually can't take the antibiotics, right? So these are sick patients, cirrhotic patients, right? Again, maybe actually rifaximin may benefit them. But again, some of these patients really sick, cirrhotic, scleroderma, and they found, so Saccharomyces was one, VSL3, another blend, had significant reduction in SIBO, and even VSL improved transit time. So I just wanted to kind of paint a picture that there are some studies about natural options. Another one is looking at sun fiber, PHGG. Another one is fecal transplant. I think, is it just one study, Dr. Rezaie, on fecal transplant? I think they did with the capsules.
Yeah.
SIBO. I mean, and the gut microbiome diversity of the FMT group had a great increase, of course. GI symptoms significantly improved in SIBO after the FMT. So I think that just to understand, there's not one approach to healing SIBO. I think a lot of people, have options, but
Mhm.
just to do them safely, to have like a good practitioner they can talk to, they can get tested with, and take that
Mhm.
journey in a really safe, planned out way to get the best results.
Perfect.
So one point I wanted to ask though, because anecdotally I've had success with it, and also you have a lot of experience with it, the fennel seed and magnesium, I definitely use that, and it's working really well with my patients. So I just wanted to understand how does it work and what does fennel seed do? Do we know, or how does it work?
Thank you so much for bringing that up. So, interestingly, this is a product that I'm a part of creating. So, it's a fennel seed magnesium oxide product. And so, this product really came in to be a little bit more of the support for the maintenance and motility phase. Now,
Mhm.
the interesting part is because fennel does have some antibacterial,
Mm,
antifungal properties. There was a study from California, I think it was UCSD, where they even
mm,
looked at it in IBD and for helping intestinal permeability. And
mm,
so, again, these are small studies because herbs don't have like a big pharma
mm,
background to support their use. But so what we did was we really looked at the ACG AGA guidelines for constipation, right?
mm,
Magnesium
mhm,
oxide, safe. That's the one that,
mm,
they recommend as far as a magnesium type. And then the fennel seed has been described by, some of our gastroenterologists, like at the different conferences, like Anthony Lumbo from
mm,
Harvard, right? And he's written about using fennel seed. Similar
mm.
sometimes also to peppermint, has that relaxing quality for spasm, and which can lead to ineffective motility and pain and so many things. And so I would say this is definitely not an eradication, that combination. It's not what I would recommend for pure eradication, but I think it is a really great support for people on the journey, for their motility support, and again, some candida effect and intestinal permeability support.
Well, fennel and Ayurveda are certainly, that's an ancient approach for digestive support. You eat an
Yeah,
Indian meal and afterwards you grab those little seeds afterwards to help with the bitter and all of that. That's amazing.
yes,
Okay,
yeah.
ladies and gents, we got questions for you. So many questions. You ready?
Mm.
If someone with frequent SIBO relapses, any advice on what to do next or how to extend remission beyond 3 months?
How should we handle? You want to just go back and forth? Do you want to
Sure,
take the first one? It doesn't
sure.
matter.
Dr.
It,
Rezaie, take that one if you would.
oh yeah,
Yeah.
I'll take that because
Or,
Dr.
yeah.
Ivanina covered that. So the pro-motility drugs are now our mainstay of a therapy with that situation. Obviously, we make sure that in terms of diet, we're modifying things that patients are not taking something that is super fermentable that is like causing the relapse. But usually, patients with multiple relapses of SIBO are very diligent about their diet. So we reach for pro-motility drugs. And these pro-motility drugs are medication that activate the housekeeping waves. Remember, during fasting, every roughly 2 hours, a wave comes in and tries to clean the small bowel from the residual bacteria and residual food, and it cleans it essentially. Just literally housekeeping every few seconds, 11 times per minute to be exact. It just pushes things forward and milks the small bowel and pushes forward. And now these contractions are mediated by multiple receptors. One of them is motilin. And motilin receptors can be activated by erythromycin, for example, or azithromycin. So that's why you hear using low dose erythromycin or azithromycin. Also, serotonin receptors, especially 5-HT4, activation of that helps. So low dose, for example, prucalopride, we do use it. Now, activation of vagus nerve, that also helps that. Now, I know colleagues use like vagus nerve stimulators, or we do even use mestinon as a treatment, which increases the amount of acetylcholine, which is how a vagus nerve works on the muscles in our gut. So those are some of the pro-motility drugs that we use. I know there are like multiple other ones, but those are the classic ones that we reach for. Now, do I have patients that unfortunately even pro-motility drugs don't make a dent in that situation? Yes, we do. That's a time that we go back again, reassess. Am I missing an underlying cause? Exactly what Dr. Ivanina said. Okay, good. What am I missing? Where is it? Is this something that is modifiable that we miss? So that's one important thing. And other things that we use, we try to avoid chronic antibiotics, obviously, at all costs. But again, rifaximin long-term has good safety profile. And also, replacing one meal a day with elemental diet has been tried in patients with chronic pancreatitis in a large study in Japan, more than 500 patients, 280 centers. And that was very effective. And they did that for actually a 12-week period. And so that's actually one trick. So that I sort of replace breakfast with elemental diet, and they can have their lunch and dinner, and to see if that kind of keeps things at bay. We're hopefully doing a clinical trial soon, addressing that to see how that affects the microbiome in healthy subjects. So those are the tricks that I use to address refractory or recurrent SIBO cases.
On top of that, can Embiata elemental diet be used while the intestine recovers from celiac damage?
So specifically, well, that there's an ongoing trial with that.
Okay,
And
great.
yeah, in the past, there are two studies that have been published. One with refractory celiac disorder that elemental diet showed to be effective. The other one is a refractory dermatitis herpetiforme associated with celiac, which is the skin rash associated with the celiac,
Okay.
which sometimes, interesting enough, doesn't respond to gluten-free diet. So there are two small studies that elemental diet has been effective in those patients. Now, can it help with the gut permeability issues that clearly exist in celiac? Theoretically, yes. I don't have any data to back it up. No.
Okay. All right. And Dr. Ivanina, question for you about Hashimoto's and hypothyroidism. Can you explain how those lead to SIBO?
Sure. So I think there was actually a study out of Cedars-Sinai that was published from, I think it was probably a joint endocrinology GI study, looking at hypothyroidism. So that's Hashimoto's, and looking at hypothyroidism, which I think one of the biggest connections is the hypomotility, right? So when you, first of all, think about Hashimoto's hypothyroid versus hyperthyroid, right? People who have hypothyroid have sluggish motility, very much the opposite of hyperthyroid. And, I think that the things that have been looked at are changes in the microbiome and changes in intestinal permeability. So again, if you put them all together, as a lot of people have this condition for so long before they actually get treated with replacement. And when they get treated, I believe the study showed, right? Then, again, these things resolve. Your motility gets better. Like, things will all improve. You just have to get the diagnosis and the right treatment. Again, it's a true root cause condition.
Perfect. Okay. And should you stay on a prokinetic while on the elemental diet?
So, yeah, do this case by case, I have to
Okay.
admit, because elemental diet, some people get loose bowel movement. I mean, the majority of people get a loose bowel movements on it. So now you have motility on board, obviously you can get diarrhea. So that's what you need to be careful about. Having said that, there is another subgroup of patients that stop having significant amount of bowel movements with it. All right. So in those cases, actually, I continue the promoted drugs. In people who get loose bowel movements to a point that it becomes a little bit annoying, obviously, I stop it. So I do it case by case, at least in my practice.
And for Dr. Ivanina, if untreated, how long can SIBO last?
Oh gosh, if untreated, I think that there's probably no end point. I think that once you develop that type of dysbiosis, people have daily symptoms. It's not like one day have it, one day you don't. Like, this becomes your microbiome until you do something about
Beautiful.
it.
Yeah.
Perfect. Okay. And then is our last question. Can you please mention, Dr. Rezaie, why cyanocobalamin, I don't know if I said that right, is used in Embiata rather than methylcobalamin for B12?
Right. I mean, the whole concept of whether we use methylated vitamin Bs or vitamin Bs. So remember, in the setting of elemental diets, the way we absorb the vitamins are a little bit different. So now we have like a direct exposure of vitamins and also the minerals to the gut. They're not like hiding in the middle of whatever, like the sourdough that you'll have. So what we have seen, at least in our patients, and we measured the vitamin levels, in the clinic. We didn't see any sort of dip. If anything, they were all repleted with that. And that was the reason that we kept it.
I think actually I'm just getting a notice from Maeve that they've updated the ingredients to use methylcobalamin. But see, so there you go.
Well, that was a clinical trial, I guess, and now we have methylated.
Okay. 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 Y'all, our time is up. I wanted to say thank you. Can we all put some love into the Q&A box and some hearts, etc.? We're going to keep rolling on time here. Your genius is so appreciated, the both of you. Keep up the great work. Godspeed. And thank you very much. We are going to do a giveaway. So we'll wrap up and say, have a great day. And thank you so much for being part of this important event and all your great work.
All right. Thank you so much.
Thank you.
Thank you.
All right. We'll talk to you
Bye.
later. Bye-bye.
Bye.